This video is on biliary colic. Biliary colic is the steady abdominal pain caused from the obstructive flow of bile from the gallbladder. This is usually due to cholelithiasis, the medical term for gallstone formation. And from this diagram, we see that the gallstone can lodge in the cystic duct, the bile duct, or even the common hepatic duct. When the gallbladder contracts against this obstructed outlet, the raised intra-gallbladder pressure causes pain in a crescendo-decrescendo pattern. It is this pattern because it mimics the contraction of the gallbladder. It is visceral pain that affects T7 to T9 nerves, resulting in the pain being felt in the right upper quadrant or in the epigastric area. If it irritates the diaphragm, the pain may radiate to the right shoulder due to irritation of the phrenic nerve C3 to C5. You may already know that CCK stimulates gallbladder contraction, and if you don't, you know now. Anyway, so this pain is usually worse after a fatty meal due to the release of CCK. The pain lasts up to 5 hours and is constant. Other associated symptoms include nausea and vomiting. Now, if there's prolonged obstruction by a gallstone, it can cause inflammation of the gallbladder. This is called acute cholecystitis. An easy way to remember it is by sounding out the name, so it's coli, bile, cyst, bladder, or sac that holds the fluid, and of course, itis, inflammation. So as we have established that gallstone is blocking bile flow, bile status causes mucose disruption and subsequent prostaglandin release. Prostaglandins cause distension, and this is coupled with poor blood flow to the area, resulting in ischemia, because you're essentially having less blood flow supplying a wider area due to the distension. And this is especially important to keep in mind when we come back to talk about complications later. Risk factors are simply fat, female, 40, fertile, and fair. But to take a more pathophys perspective, you can think about it in terms of factors relating to bilirubin, factors relating to bile stasis, and cholesterol. So to understand factors relating to bilirubin, let's very quickly remind ourselves of the metabolism of bilirubin. Bilirubin is formed in the spleen from the breakdown of red blood cells, conjugated in the liver, and then passes into the small intestines to help digest fat. So risk factors include issues in the spleen, such as chronic hemolysis. So you're breaking down red blood cells that are too young, liver problems like cirrhosis, and intestine problems such as Crohn's or GI infections. Also, factors relating to bile stasis include fasting and spinal cord injury. And finally, factors relating to elevated cholesterol include obesity, age, high estrogen levels, and diabetes. Investigations will include physical examinations, so notably Murphy's sign, and possible jaundice. Blood counts will show signs of infection, such as white cell count being elevated. LFTs will form an obstructive jaundice pattern, so raised ALPs and raised GGTs. However, the most important investigation is an abdominal ultrasound that will show the presence of gallstones, shown through acoustic shadowing. There may also be thickening of the gallbladder wall over 5 millimeters, which would be indicative of edema. Finally, we may see pericholecystic fluid, and these last two findings are evidence of inflammation. So let's briefly recap some terminology to understand the progression of the disease. So gallstone formation is called cholelithiasis. If it obstructs biliary flow and causes pain, biliary colic. If this causes inflammation of the gallbladder, cholecystitis. If the gallstone is in the common bile duct, so just in the common bile duct without causing inflammation, cholelithiasis. If there's inflammation of the common bile duct, cholangitis. If the gallstone moves down into the pancreas to obstruct the ampulla fata, it can cause pancreatitis. And this is a good foundation to think about complications of gallstones. The stagnant bile predisposes one to an infection and possible empyemas. Further, as the area is distended, vascular supply is blocked off and it can lead to ischemia. Bacterial infection of the ischemic wall leads to gangrene, which can perforate to cause peritonitis and possible death. Fistulas into the duodenum can form, and this is called a cholecystoenteric fistula, which is a complication. If a gallstone enters the bowel through this fistula, it can cause bowel obstruction, called gallstone-itis, and a rare complication is carcinoma of the gallbladder. So thinking about complications, it's most important to think about anatomical relations and where stuff can spread, as well as the underlying pathophys. Treatment of gallstone immediately focuses on pain management, so give NSAIDs and antibiotics if there are signs of infection. To remove the gallstone, a laparoscopic cholecystectomy may be performed. Thank you for watching. If you learned something, share it to a friend who may also found it useful.